So welcome everyone. Thanks for dialing in or joining in on Zoom. We're just waiting on one piece. All right, I think we are live now. Very good. So welcome to our quarterly VCSQI meeting. Thanks all for being with us tonight, live via Zoom. I know many of us wish we were at the board set tonight, but tonight Zoom will be the safer option, and hopefully, you know, in the months to come, we see a recovery from COVID, and we'll be in person at some point here in the not too distant future. Just a couple quick housekeeping items before we begin our presentations. Everybody looks like is getting connected successfully on Zoom. I imagine you've made some progress and strides with that over the last few months here. Just a quick reminder to please mute your lines. You can do so via the participants feature, or if you're dialed in on the phone, do so on your phone. This participants window is really the key to interacting. So that will bring up a chat feature, that'll bring up a raise hand feature, and that's via this little bar you'll see at the bottom of your Zoom screen for chat and the participants window. So just a brief etiquette thing. Thank you for helping us have a smooth meeting here. There is a quick piece on CMEs as well. We're eligible for about 2 CME hours. So take a screenshot of this. This is texting the same number that you normally text as far as the VCU CME system. You'll have to text your email address first to this number you text in your email. So if you're judy@uva.org, you text that email to this number, and then you have to text this 10-digit code, including the hyphen. And we'll send out a follow-up regarding this info to everybody that we see on the session. If you want to make sure we capture you, you can type to us in chat, but we are taking a log of everybody we have on the screen here too. I'll just pause a minute while people, looks like they're jotting this down here. There you go. Take a picture. That'll work. Perfect. And again, we'll follow up with that info. So we have a jam-packed agenda tonight. We'll review some data, talk about a new VCSQI research proposal, and then 2 exciting presentations, one on the shock team approach to cardiac care, and second with the Secretary of Health and Human Resources from the Commonwealth of Virginia. So without further ado, I will pass things over to Dr. Robert Shor, our VCSQI chairman, for the board. Dr. Shor.
Thank you so very much, and welcome to our Zoom quarterly meeting. I did want to say we've had really tremendous success and participation, so thank you all for doing this. One of the things we talked about at the board meeting is where do we go in the future as far as in-person versus Zoom meetings, and what are people's thoughts. And so we'll be sending out a survey with regard to meetings in the future. For the time being, we are going to do what is safest and plan for the future tentatively for Zoom meetings. But as we get through this COVID pandemic, we will have then the option of resuming in-person meetings or some hybrid with the Zoom meetings, Zoom or in person. Among the things I did want to update, and I would ask that if you're not speaking, to put your device on mute so we don't hear background music or speaking. We looked at the financials just to let everyone know. They really looked good and are very stable. Obviously, our costs are down, not having some of the meetings. And one of the things that we want to think about also is showing the value of VCSQI and what the value means to each of us going forward. We also looked at one of the items for discussion was the VHAC database And that raised a couple issues. One is, as many of you know, the AHA Get With The Guidelines and the database through ACC for STEMIs have been separated. And so what we've been trying to do is to find a way that we can merge the two together. And that would serve the purpose of having Commonwealth data less disjointed, but also a way of bringing cardiology into VCSQI in a more complete way. And so that really is something we are pursuing with the hope forward down the line of perhaps even more integration between VHAC and VCSQI, much the way we have done with cardiology as it is now, and the cardiothoracic and hospital communities. So that's one other item we'll be discussing. We did discuss the research proposal barriers to implementation of concomitant AFib ablation during mitral valve surgery, and we'll have more discussion on that, but that was unanimously supported and approved by the board for its value going forward. And then lastly, Dr. Labdell was kind enough to stay on the call and talk about perfect care through Atrium Health, a way of looking at a combination of digital health and visual meetings, remote monitoring to improve the care and cost, much the way we are trying to bend the curve, and ways that we could get involved. And so we continue to explore potential participation, understanding what the potential costs might be and ways to mitigate that for the patients and the institutions. The last thing I did want to say is that we have a wonderful, amazing meeting, and I'm very thankful for all the participants, speakers, and a special thanks to Dr. Dan Carey, who will be joining us in a little bit. So that is just a brief overview of the information from the board meeting. Anyone else that was on the board call, if you want to add or update, feel free to do so. Otherwise, Eddie, take it away.
Sounds great. Thank you, Dr. Shor. And we start every presentation off with a relook at the VCSQI strategic plan, our mission of transforming cardiovascular care to improve patient experience and value, vision of optimizing heart care outcomes through national collaboration, innovation and research, and our core values here, which again, conveniently, all start with the VCSQI acronym letters. I think tonight we'll see all of these different pieces in action together. And next we'll move into some data, a quick look at CathPCI reports, as well as vascular access practice across VCSQI centers. This is 2019 CathPCI data, utilizing standard ACC metrics grouped by hospital volume in terms of PCI procedures. We've seen this one before. This is our access site by center, low, medium, and high. Of note is the statewide rate down below. We're about 57.5 radial, 42 femoral, but just wide variation across centers between sites that are doing 10% femoral to sites that are nearly 90%. We did a drill down of looking at outcomes by access site. When we just pit all femoral cases against all radial cases, the results are statistically significant across the board as far as radial being better. This has been widely published, so nothing new, but we've seen about half the rate of different complications as far as radial cases. We broke this down even further into low risk and high risk radial cases. So comparing low risk radial against high risk, or sorry, low risk radial against low risk femoral and high risk radial against high risk femoral. And even within the low and high risk groups, there were significant differences between populations in almost all scenarios.
Eddie, can I just interject a quick comment? We've talked about and showed the data between vascular access, and one of the issues that came up was, well, some of the centers are doing sicker patients and higher risk patients, and they need to be done from the femoral. And so we really thought we would break out the radial versus femoral approach and include some of the risk stratification along with it. So that's what this presentation is going to be outlining to a certain extent. We wanted to then offer some opportunities for improvement and then open up for discussion. So we'll be reviewing all this data, confirming some of the differences that we've known about, and then trying to create some strategies to improve care and cost.
Thanks, Dr. Shor. So our next set of slides delve into the data even further. This shows two different high volume centers as an example here in terms of percentages they're doing femoral versus radial. Site 5B does about 3/4 of their cases via radial access. G2 is 85% femoral, 15% radial. When we look at the low risk patients, there's more radial cases at each center, but there's still a high proportion of femorals at G2 and a much higher rate of radials at 5B here. When we look at the high risk patients, 5B does more femorals in that case, but site G2 is nearly 100% femoral for those patients. So one example of disparities we're seeing even among two high volume centers within VCSQI. This is an outline of the predicted risk of mortality across centers, femoral versus radial. In general, femoral cases are higher risk. You see radial, the average risk is actually pretty low across the board. Femoral, it's higher. But again, as we saw a few slides ago, that doesn't explain the entire variation in outcomes between the two. Next, we delve into a few of the specific outcomes by center. I'm going to go through these kind of fast. We've seen some of these before. This is just updated data. Of note is we look at the VCSQI line on each, twice for femoral versus radial, and a lot of variation between centers. Bleeding, this is red blood cell transfusion. Please stop me if you have any questions or comments.
Again, just to point out, these are the patients that did not get bypass. So we pulled out all of the patients that underwent bypass. This is PCI without bypass.
Correct.
And one of the other issues that we were concerned about is, as we look at the different volumes, is what is the N? And the number that's involved in all of these is significant. You can see this one is more than 9,000 patients. So the data looks pretty robust.
Same piece with fluoro time. As well as length of stay. I'm going to look briefly at AKI rate. This actually only incorporates about 2/3 of cases just based on when, what patients had creatinines drawn both pre and post procedure. So you notice the smaller N at the top. There's still about twice as high of a rate for femoral cases versus radial. We next wanted to explore whether this was related to contrast volume. And indeed, there seems like there's a sweet spot with regards to the amount of contrast given, and the lowest AKI rates occur between about 125 and 150 milliliters of contrast. So discussion. There's still wide variation. We've shown that this is independent of severity of disease. Generally, the femoral cases are having higher complication rates. So the question is, how do we progress from a system level here? This was one article that was shared as well with regards to reducing the incidence of contrast-induced AKI.
So this was from Jack, a review guidelines with regard to catheter and contrast-related AKI that should be on our website. I think Sherry was putting that on our website. But it does, as the central illustration points out, have a variety of things. Included in it is contrast-sparing strategies, radial access, et cetera. And so this is further fruit for us as an institution and at our health systems to kind of look at how we can impact that. And one of the easiest things might be looking at vascular access, along with implementation of hydration, et cetera.
Very good. We also had an example of a best practice shared with us from the COPE group in Washington. COPE is the Cardiac Outcomes Assessment Program, which represents 33 different interventional cardiology practices, as well as a number of cardiac surgery hospitals within the state of Washington. I'm afraid we're a little short on time. We'll send these slides out later. Dr. Shor, would you like to summarize, though, a couple of the key components as far as COPE's protocol?
Sure. I think identifying a champion, having everybody on board so that you have to speak with the peers about the concerns. There is going to have to be a transition, and where there has to be enough support and guidance in that training period to transition from femoral to radial. It's hard to know because we don't know the hospitals, whether these are older operators, younger operators, whatever the other indications for why they may be doing more femoral cases. So from that perspective, there are a variety of things that you can see from the COPE strategy, but each system, if you're doing high femoral, should probably look at opportunities and ways to transition those that are more femorally access-based than radial. There are other considerations, radiation exposure, established standards of care and team training. The processes become hugely important. And you can see special considerations for radial access and STEMI, reduced complications, greater patient satisfaction, but it all is based on the comfort level of the operator doing it radially from versus femoral. Eddie, do we have time for any discussion or comments? Or we're right up at the...
I think we're about at time. Maybe one comment or question, if there are any out there.
And while people are about to talk, the other thing you can do is in the chat, you can ask a comment or ask a question or make a comment, and we can share that with everyone either now or later as well.
Perfect. Thank you, Dr. Shor. Next, as you mentioned earlier, we will discuss a new survey with regards to implementation science. So I'm pleased to introduce Dr. Hunter Mehaffey, a surgical fellow from UVA. Dr. Mehaffey will give you an idea of what's to come here with our new study on concomitant AFib ablation during mitral valve surgery.
Thank you, Eddie. Thank you, Dr. Shor, for the opportunity to have a moment of the meeting. Eddie, I accepted the share, but there we go. So I appreciate the opportunity to talk about this collaboration between the Cardiothoracic Surgical Trials Network and VCSQI. The CTSN started back in 2007. It's funded by the NIH and conducts clinical trials in cardiac surgery. And they have conducted a number of trials over the last 10 years. But with the most recent funding cycle, the NIH has asked us to have a focus on implementation science. And they're really interested in understanding, are we adopting the evidence-based practices that we're identifying in these clinical trials? The NIH is really trying to get a better understanding of their return on investment. So the first question we elected to tackle and look at is concomitant atrial fibrillation ablation during mitral valve surgery in patients who have preoperative atrial fibrillation. So in 2015, the CTSN published a clinical trial where they randomized 250 patients undergoing mitral valve surgery with pre-op AFib. They randomized them to either ablation or not. During the operation, there was also within the ablation arm different approaches to ablation. But what the final study demonstrated was that not only was there no increase in adverse events perioperatively, there was a slight increase in pacemaker rate, but at 1 year, importantly, there was a significant reduction in atrial fibrillation in the patients who underwent concomitant ablation. This study led to 2 years later, the Society of Thoracic Surgeons publishing their clinical practice guidelines for the surgical treatment of atrial fibrillation. And within these guidelines, they list concomitant AFib ablation during mitral valve surgery as a Class 1A recommendation with randomized control evidence. So since since these two publications, did practice change? That was our question. So this study was presented at the STS meeting this past January. This is VCSQI data. We looked at the rate of concomitant AFib ablation during mitral valve surgery in patients with pre-op AFib. And what you see in blue here is that, in fact, over the study period, which included the publication of these two papers, our rate of concomitant ablation actually went down. And that's despite an increase in the rate of pre-op AFib, so patients coming in with pre-op AFib who would meet the guidelines. What was even more interesting is when we look at variation by center, just as we were talking about with the CathPCI data. So this graph orders the 19 cardiac surgery centers within the VCSQI from highest to lowest mitral valve surgical volume. And what you see is the rate varies from around 30% to almost 100%. But even within the top 3 highest volume centers, the rate was anywhere from about 40% to up to 80%. So there's just a lot of variability across centers for this Class 1A recommendation. When we dove in deeper and looked at the specific patients, what we see is patients who underwent concomitant ablation were more likely to be young and have persistent AFib. They had less comorbidities. They were lower risk patients. They were less likely to be reoperative, less likely to be urgent, and they had a lower STS predicted risk score. And as would be expected, given these preoperative factors, they had superior outcomes. There was a low rate of composite major morbidity and mortality. They had shorter hospital stays, lower costs, and importantly, only 10% were still in AFib at the time of discharge compared to 53% of the patients who didn't undergo ablation. And finally, when we did the risk-adjusted analysis, we demonstrate that in this large real-world population, concomitant ablation did not significantly change major morbidity or mortality in a risk-adjusted fashion. So now that we understand what the practices are and what the clinical patient-level retrospective data is, now the next step is identifying the barriers to implementation. So our team of collaborators has put together a survey for all of the cardiac surgeons within the VCSQI. 5 to 7 minute survey. You can complete it on the computer or on your cell phone. The link will be going out after the meeting. And the real targets of the survey are trying to identify volume-related factors, referral issues, what training surgeons have and experience, what resources are available at each of the hospitals, as far as some of the decision-making that goes into case selection and the current barriers that surgeons face. And the final questions discuss what approaches that we can take to overcome these barriers and to improve our adherence to these guidelines. We're going to identify a point person at each institution to try to help us reach 100% participation from all the surgeons. So definitely let the folks at your institution know that this is coming, and encourage them to take the 5 to 7 minutes to complete this, so that we can improve this adherence to guideline-based care. I really appreciate the time. I'd be happy to take any questions or any thoughts.
This is really fabulous. And we talked about it, Gorav talked about it at the board meeting, and we were all in support. So it's an important step.
Other questions, comments?
Yeah, this is Gorav. I want to also add that if this is successful, I think this survey platform can be used for any number of quality / implementation projects that surgeons or cardiologists wish to undertake and try to identify barriers. And then the next step after we identify the barriers is to try to address the barriers. And I think ultimately this is what the spirit of VCSQI is all about. And other thoughts from the cardiac surgery standpoints, like the utilization of bilateral IMA, and maybe from a cardiology standpoint, it's utilization of radial, although I think it's already pretty high in Virginia. But there are probably things that are not as universally utilized in both surgical and cardiology literature, yet there's strong clinical evidence of benefits. And identifying what the barriers are could be very, very helpful. Sometimes it might be a financial, that there's no financial benefit for bilateral IMA or minimal. So why surgeons don't all adopt that because of reasons. And, is that something that VCSQI can address? So hopefully this survey mechanism will work well. We'll of course report it back to you. And if there's learning points, and if there's other projects in the future, I think this is a great opportunity.
Certainly. And feel free to email Eddie, myself, or Michaela, who will be sending out the some survey links. We're happy to answer any questions or troubleshoot anything that everybody runs into.
Wonderful. Thank you, Gorav. Thank you, Hunter. Looking forward.
Okay. If I could just make an introductory comment. One of the areas that we talked about as we integrated cardiology into the VCSQI community is areas where we find there's a lot of collaboration between cardiology and surgery and decision-making. And one of those high-risk areas was, how do you manage cardiogenic shock? So in that effort and in that spirit, we sent a survey out, as you all know, to the institutions, asking if they had shock programs and were they developed, and the variety of questions. The next step really is to discuss what does a successful cardiogenic shock heart team look like. And the next after that will be to share best practices and other ways that we can monitor impact outcomes and cost. So we are extraordinarily grateful to Behnam Tehrani, who will present the Inova experience on cardiogenic shock. He is lead author in one of the most highly reviewed and cited articles on shock. This just kind of exploded in our literature and the interest. So it's a delight to introduce Behnam.
Thank you, Dr. Shor. Thank you, Dr. Spear, and for everybody at the VCSQI for inviting me. It's actually my privilege to be here with you today. And for the next 30 minutes, I wanted to discuss with you just how our process for shock management at Inova has been, and share our insights of what we've learned with this. So we truly here call it a hard team approach. It's a team-based management of these patients. Can I roll the slides, or how does that work?
Yeah, you just need to click on the Zoom window and you should be able to control the screen.
So, why are we all here? And many of you have seen this data, and you're all very well aware that, despite significant advances in cardiovascular medicine with early reperfusion, with the formation of regionalized systems of care within our communities and around the country, and with the advent of robust mechanical circulatory support devices, survival in shock has been very poor. When you look at the initial shock trial, which showed that we were able to improve survival from 20% from the days of Dr. Killip and Kimball when they formed CCUs to early revascularization, that was a big milestone. But since that time, really survival has plateaued in these patients with mortality rates in excess of 40%. It's been shown in a number of studies. ISTAR shock was one of the studies that looked at a balloon pump and Impella, which showed that Impella has better hemodynamics, although survival is unchanged. The IMPRESS and severe shock trial looked at patients with cardiac arrest. Culprit shock, which looked at culprit versus multivessel revascularization, AMI shock, and then 6-year data from the IABP2 shock study, which showed that really these patients are really high risk, not only in the acute setting, but long-term with surrogate endpoints of heart failure, higher need for ICDs, higher need for rehospitalization. So from a short-term and a long-term premise, this is truly a problem. And this is a disease process in which incidence is on the rise. You look at data from the left. This was just published within the last 2 months out of CCI by the Minneapolis Heart Institute, and they looked at their STEMI program over a 15-year period. And they showed that actually the incidence of shock and cardiac arrest, but in particular shock, was on the rise. And so now patients that come into their network with the STEMI, over 11% will have cardiogenic shock. And that's part of the reason why their STEMI mortalities have actually gone up rather than down. To the right is data that was published from the Danish registry just last year out of the European Heart Journal, and that was over the course of a 7-year period in which they showed that the incidence of shock was on the rise and outcomes were unchanged. And so these are patients that are much sicker than were seen before. They're older, they have a higher burden of comorbidities, and they have a greater degree of hemometabolic derangements. And as we all know, this is a disease process which is very complex, multiple phenotypes in terms of how they can present clinically pre-shock. They can develop fulminant shock. And many of you have seen these figures in different iterations in which over the course of minutes and hours, not days or weeks, these patients will go down a very quick proverbial quote unquote death spiral in which they develop end organ failure, marked metabolic derangements, up to 20% can develop systemic vasodilatation due to a systemic inflammatory response cascade, and the ultimate and the common final pathway is unfortunately death. Our colleagues at SCAI last year put together a classification scheme, the first of its kind in shock actually, in which they classify these patients in an A through E scheme: at risk, borderline shock, classic shock, deteriorating shock, and extremis. And they put together actually this classification scheme using 3 cross-disciplinary domains, which I think is the emphasis of today's talk, is that it's truly team-based. So physical exam findings, biochemical assessments, and hemodynamics. So whether you're a cardiologist, an intensivist, a cardiac surgeon, an ER physician, these domains really fall within all of our wheelhouses as we assess these patients, and we decide, what is the best next step in terms of course of action. And this classification scheme was validated last year retrospectively, first with the registry out of the Mayo Clinic, and they showed that each rise in the SkyShock classification scheme correlated with increased CICU and in-hospital mortality. The Germans just validated it earlier this year, looking at 30-day outcomes. And interestingly, they also added what's called an arrest modifier. So what they showed was that when you add an arrest on top of cardiogenic shock, we've all known this for a very long time, the stakes are escalated, especially as somebody comes in with an arrest, with shock, and they have an arrest, and the initial rhythm was a non-shockable rhythm. And so, as we've talked about it, not all shock is equal. Dr. Dan Burkhoff and his colleagues put together this really nice white paper out of Circulation just a month ago, in which they looked at these patients and they classified them as classic LV dominant shock. So, we think of a low cardiac power output in addition to hypotension, elevated wedge, normal to borderline high CVP, but primarily left-sided. And then there were those that were RV dominant shock. And these patients actually were up to 37% of the initial shock registry and that high mortality, and then BiV shock. And when you look at the all the data, between 40 to 55% of patients that we initially may think had just had purely LV shock come in with BiV failure, as evidenced by elevated left and right-sided filling pressures and congestion, and they have higher mortality. And the cardiogenic shock working group out of Tufts showed that. Interestingly, and I think this is where there's a lot of opportunity for improvement, is the patients with pre-shock. The patients that come in, at first glance, they're awake, they're mentating, they have a blood pressure of 110, 120, but they may be tachycardic, they have a lactate of 4, and they're really compensating for all that low output with a lot of afterload. And these patients, while they only comprise 5.2% of the initial shock registry, they were probably the sickest cohort of all the patients. They had a higher burden of anterior wall MIs, and they had a 43% in-hospital mortality. And we all know this, cardiogenic shock, these patients are coming into to our community. They don't always go to academic medical centers that may have 800, 900,000 beds, or doing 11 or 1200 PCIs. These patients are part of our community. They'll go to medical centers, which maybe what we'll classify as level 2, so they have a cath lab, balloon pump, plus or minus Impella capability, or they may go to a facility where we just have an emergency room. And it really emphasizes the point why it takes a team-based approach to identify these patients, and really using a one-call system, which what we put together here at Inova, get them to a level 1 center where they can get full spectrum acute cardiovascular care with destination therapies, be that whether it's advanced high-risk coronary revascularization, LVAD, transplant, or the like. And again, there's a lot of disparities around the country when we look at outcomes. So this group out of Mayo Clinic put together their data in which they looked at these patients with shock coming in, whether they were at rural hospitals, urban non-teaching hospitals, teaching hospitals, whether they were small, medium, or large, and the outcomes are very disparate in terms of how these patients will typically do. Usually what they saw was that if they were at an urban teaching hospital, the outcomes were usually better than if they were at a rural non-teaching hospital. But again, it just goes to show that in the absence of adequately powered randomized controlled trials to inform clinical practice, really practice becomes anecdotal, and patient selection unfortunately lacks uniformity. And one of the reasons why there's such poor outcomes with management of this disease process is practice pattern variation. And something as simple as a right heart cath, which albeit fell out of favor after the papers by Dr. Connors and colleagues, is very underutilized. To the left, you'll see data from the nationwide inpatient sample put forth by the group out of Harvard. And over a 1-year period, 2014, so you would take it with a grain of salt, the highest quartile MCS utilizing centers utilize a PA catheter in less than 6% of the time. And to the right, this is a 7-year data by the group out of Mayo Clinic, again, using the same database. If you look at it, whether you're in the Northeast, the Midwest, the South, or the West, if you're having cardiogenic shock, a PA catheter will be used less than a quarter of the time to guide care. And for those of us who take care of these patients, we realize how tenuous they are, how dynamic their situation is, and how important a right heart cath can be to help guide care. And we all know this. The current therapies do have limitations. The more pressors we use at a higher dosage, the poorer the outcomes. And this is data that goes back 20 years ago. Dr. Samuels and colleagues, and again, just within the last couple of years out of Detroit with their national initiative. And so what's the current paradigm in managing these patients? So, with the first angioplasty by Dr. Grunzig and colleagues in '77, the emphasis has really been on getting the artery open early. What's called, what was Dr. Brunwald's favorite term, the open artery hypothesis. And this kind of really spurred all the discussions around door-to-reperfusion metrics and, coming together with these door-to-balloon times. But there's some question, there's some theory about whether reducing demand in these patients can stave them off. And so for 40 years, there's been preclinical research looking at what we call ischemic preconditioning modes of therapy to help reduce demand, whether you're a believer in mechanical LV unloading, pharmacologic methods, mechanical methods, something as simple as putting a blood pressure cuff in the arm and inflating and deflating in the ambulance prior to going to the cath lab. And this is something where we're kind of at an inflection point. And obviously, we believe the door to unload STEMI trial should at least help to inform us in terms of whether unloading the ventricle before PCI may change outcomes. But for now, early reperfusion is the marker. And the reason why this is important is because as good as we've gotten in terms of getting these arteries open earlier, as you can see, this is from the NCDR database 7 years ago. With median door-to-balloon times, close to 70 minutes, mortality is plateaued. So clearly, we've made progress, but there perhaps is more room to go in the care of these patients. And infarct size contributes to hospitalization and mortality. So we've known this for a long time, that scar is very important. How much scar a patient develops after an infarct will really dictate what their outcomes are going to be long-term. And Dr. Greg Stone and colleagues showed this in their paper very nicely. They did a pooled analysis of 10 primary PCI trials, and they showed that for every 5% increase in infarct size, you're going to have about a 20% increase in your 1-year mortality and in your 1-year rate of rehospitalizations. Sorry about that. And so the PA catheter, as we talked about, was written off. So not too long ago, where the obituary to the PA catheter was written off, was written by colleagues of Dr. Connors, in which the thought was that a PA catheter may not only not help in terms of guiding therapy, but may be associated with iatrogenic harm. We've known now for the better part of almost 2 decades that there's important granular data that can be garnered from something as simple as doing a right heart cath. And one of those is a cardiac power output, which is your mean arterial pressure times your cardiac output over 451. And when that number is less than 0.6, as you can see here, really mortality shoots high. And this has been validated as a very important marker of in-hospital mortality. A group out of Detroit showed this, that when you don't clear your lactate and when your cardiac power is low, 12 and 24 hours, survival, unfortunately, is not very good. And again, I will say the PA catheter has not been studied in randomized controlled trials, either for patients that come in with shock or patients that have a shock and get therapy. But we have retrospective and observational data. Again, we take all this with a grain of salt, and the data shows that a PA catheter may be associated with improved survival. This is a paper that was published by Dr. Lindenfeld group just a year ago, again from a nationwide inpatient sample over the course of 14 years. And that for patients with shock, not heart failure, but shock, a PA catheter was associated with reduced mortality and in-hospital cardiac arrest. So again, a diagnostic modality which can provide us a lot of valuable information in terms of right-sided function, left-sided function, in terms of the amount of afterload, pulmonary vascular resistance, all these markers that we really follow closely in the care of these patients. And again, not just the same as not all shock is equal, not all mechanical circulatory support devices are equal. These devices can be put in different manners in different locations. They provide a different amount of support. Some support the LV only, some provide support to the LV and the RV. And also there is some component of afterload. I will say none of these have been validated in any sort of prospective randomized controlled trials. So that's why when you look at the data and you look at the clinical guidelines, they do receive a class 2B level evidence C recommendation in terms of empiric utilization of mechanical circulatory support. So the talk is not saying that we are advocating for any one particular device, but to use a device if we think it's necessary to really tailor to the individual patient's phenotype and their disease process. And as I mentioned, these all work at different levels of the pressure volume loop in terms of reducing afterload, in terms of really modulating all those complex pressure volume loop relationships that need to be looked at in the care of these patients with shock. And again, as I said, all these devices, at least the axial flow and the centrifugal flow, so Impella and ECMO and Tandem, they've been shown to provide better hemodynamic support. When you look at the associated vascular complications, which can be seen with large bore devices, unfortunately, those are associated with a higher degree in these devices. And ultimately, what we care about the most, which is the clinical endpoint of mortality, it's really a state of clinical equipoise when you compare these devices to their inferior cousin, the balloon pump. And again, the data suggests that MCS is on the rise. It's been really a rise over the last 5 years. It's corresponded with a decline in balloon pump use following the IABP Shock 2 trial, and when the Europeans downgraded that to a class 3, and the US it got downgraded to a class 2B. But devices are being used more frequently, and if you look at data around the country, it would suggest that when it's used at centers that are high volume, that have teams that have expertise in vascular access and troubleshooting, it may be better at those sites than centers that do very few and may not have all the appropriate expertise to take care of these patients. And so, I think the whole concept here is, if you are going to use a device, if you are going to have a team-based approach, it's not only about just raising the blood pressure. If you raise the blood pressure, it looks really good on the monitor, but we really don't know what's going on inside. And so it's important to obviously provide adequate coronary perfusion, provide adequate circulatory support, but also to provide adequate unloading to the right and or left ventricle as appropriate. And so this paper that was published by Dr. Thiel and colleagues out of Germany, this really showed what we've all known for a while. 25% of patients with shock will live no matter what we do. They have a good selection. They are predestined to survive. 25% unfortunately will die no matter what we do. They will come in, and whether it's too late, whether they came in too late. Unfortunately, we're starting to see some of these now in the COVID era with people that are staying at home and coming in with mechanical complications. These patients, unfortunately, are not going to do very well. End organ failure, severe metabolic compromise, coinciding infections. But it's the 50%. It's a sweet spot. The people in the middle that we have an opportunity to make an improvement, to improve survival from 50% to 70 to 75%, which would really impact not survival, but also do very good justice to our community and to the patients that we serve. And so it's important to identify the device early, the optimal device support, and to minimize complications. And so this comes down to what we've done at the Inova Heart and Vascular Institute with Dr. Spear and Dr. Shor's leadership, is developing a team-based approach. This paper was actually published 5 years ago out of the Sky Journal, and there was another paper that just came out a month after that in JAMA Surgery, in which they called for action to develop a team-based approach, similar to what we've seen with trauma teams, sepsis teams, stroke teams, to identify the key players involved in the care of these patients. The reason why is very simple. Complex patients, too much practice pattern variation. We don't have randomized controlled trials. We don't have a lot of class 1 evidence A recommendations. Second reason, it's important to have these teams, develop them, and develop best practices within a few centers, and then spread that knowledge to the community in terms of regionalized systems of care with hub and spoke models, and ultimately see it to improve outcomes, to really utilize our resources, especially during times like now when we're very limited, in a very efficient manner to really enhance outcomes in these patients. And as you can see, the data has been shown, whether you look at stroke teams, whether you look at tumor boards in oncology, critical care, team-based care to medicine really can have very fruitful rewards if it's implemented thoughtfully and carefully. The group out of Duke showed this, that when they implemented their aortic team, not only did their volumes go up, but not only did their outcomes improve, but also their volumes went up. So they got increased referrals, and they were able to provide these patients with the best level of care. And we see this now with vascular teams, with if you guys are on Twitter, the CLI fighters, obviously PE response teams. This has really taken off. The heart team approach, as you guys know, initially took off after the initial Syntax trial, and then the partner trial. So first with complex coronary artery disease, and then with transcatheter-based structural heart therapies, to really identify these patients to receive cohesive multidisciplinary care, patient-centered, appropriate risk stratification, to enhance outcomes, and ultimately to facilitate research which may then inform therapies and practice down the road. So at IHVI, we undertook this approach. As you can see here, we started this back in July 2016 with Dr. Spear's leadership, Dr. O'Connor, and our IHVI executive leadership team here. We brought all the key team, the stakeholders. So here, our team is comprised of interventional cardiology, cardiac surgery, advanced heart failure, critical care, and the emergency room. We put together a protocol. Our team went live January 2017. And this is a bit of an older slide, but I can tell you as of now, in June 2020, we've had over 550 patients that we've followed in our registry. And again, when we looked at our current state at the time in 2016, it was very simple. The care was fractured. There wasn't a multidisciplinary evaluation. Oftentimes, these patients were detected late, so they did not receive the therapies that they could benefit from earlier because they were getting the therapies too late, or they were recognized too late. There was impaired access to care, and obviously, when there is a paucity of randomized clinical trials, there is a lot of practice pattern variations. And so, under the leadership of Dr. Spear and Dr. O'Connor and our team here, we put together this protocol with laminated cards that we really spread across, our 5 Inova hospitals here in Northern Virginia, but also our other hospitals that we work closely with, to really make sure that if a patient comes in with shock, our ER colleagues who are very busy taking care of a lot of patients at least have the resources to clinically identify shock, know what number to call, to get the patient to where they need to be, which is to either the cardiac cath lab or the ICU, where they get ongoing serial reassessment. And so, when you look around the country, you look at the Wellstar Health System. When you look at Detroit, and now Ottawa just published their data, and even Utah, a lot of them focus on AMI shock. What we did here, we wanted to take a more of a global picture of the care of these patients, was look at acute coronary syndrome and non-ACS shock using hemodynamics with PA catheters to identify them early and make sure they get their care. And when they go to the ICU, to take a nuanced approach to the care of these patients, that if they are in refractory shock, classify what kind of shock they are in, and then offer them a tailored, nuanced approach to mechanical circulatory support as needed. We published our data last year, again, in conjunction with NCSI and also Utah, and we were able to show that at least using this approach, we were able to improve our outcomes to over 70% survival. We developed a risk score, and our risk score takes into consideration age, cardiac power output, whether they're diabetic, on dialysis, if they have RV dysfunction, if they're on pressors for a longer period of time. And this is in conjunction with what the National Shock Initiative showed, and we show that these can portend in terms of outcomes. For 2019 and for 2017, 2018, and 2019, we've had sustained improvement in our outcomes, and we're happy to see that using this team-based approach, starting from a baseline of 47% in 2016. And the patients are still very sick. So, one of the things you always worry about is whether there's going to be creep, where you're identifying patients earlier or taking patients earlier for therapies. But as you can see here, using lactates, using card shock scores, which was validated out of Europe, these are patients that are very sick. They're coming in with high lactates, higher risk for mortality, higher rates of end organ failure. But again, we're able to offer them the best chance at a meaningful outcome. Again, as you can see here, within our health system, about 60% are transferred, 40% come directly to Fairfax Medical Campus. We're about 53-47 decompensated heart failure and AMI shock, and just like many other registries around the country, it's about 70-30, 70% men, 30% women. And we have a hub and spoke network in which level 1, level 2, and level 3 centers work together. We are the level 1 center within our network. We work closely with level 2 and level 3 centers to identify these patients, to get them to where they need to be, and offer them early and timely care. So in conclusion, what have we learned? What has been our experience here? We are a learning organization under the leadership of Dr. Spear and O'Connor. We're obviously always learning. We're always taking the initiative to develop new approaches to care that's multidisciplinary. But our approach has always been activate the team for patients that you suspect are in shock. A right heart catheter does not take much time to put in, and there's very little risk associated with it, and it can actually help to inform the therapies. Vascular access, we were talking about it earlier at this meeting. Vascular complication is what ultimately does a lot of these patients in. You'll get the artery open, you put a support device in, you go home. But if you have a vascular complication, it can be fatal. So ultrasound, vascular access, using antegrade perfusion catheters, making sure that before they leave the lab, they have a final runoff angiogram. Make sure that when they go up to the ICU, all the team members are involved. Have protocols to wean and or escalate. Develop a team-based approach. Use all the resources that are available, and obviously mandatory quality meetings to evaluate all these cases. So we are privileged to be part of a lot of registries. We have our own IRB registry protocol. We're also part of the Cardiac Safety Research Consortium out of the FDA. We also participate with Tufts out of Boston with the cardiogenic shock working group, and we're also now under the leadership of Dr. Sinha, our CICU director, part of the Cardiac Critical Care Cardiology Trials Network, and we're constantly always looking for ways to improve the care of these patients and to be involved in clinical trials that will hopefully inform therapies. Thank you very much for your time. I appreciate it.
That was a whirlwind. Thank you, Behnam. And the work that was done in the heart team at Inova was amazing. Questions? And also, Eddie, did you have the survey, any survey results when we had sent the survey out to the folks? Questions from anybody for Behnam?
Dr. Spear had one via chat.
Behnam, that was just, again, every time I've heard you modify this talk, it keeps getting better, and congratulations on the specific approach to this very difficult and challenging issue. It was a little confusing on this not all shock is equal on the left dominant and right dominant, in that the numbers look, they're so comparable except for the capillary wedge, which can be measured in error. But what would you lead us, because the treatments of these are quite different. And when the echo is showing hypocontractility on the right, it can be biventricular as well. What would you lead us to do in this setting? Is this for earlier mechanical support intervention? Where does Impella play a role in the VA ECMO? Is that used routinely in your estimation? And should we default to that sooner? And what have we learned about the vascular complications related to this approach?
Absolutely. It's a great question. So just like Dr. Spear said, in patients that are coming in with LV failure and their RV looks like it's very brisk and hypercontractile, we may be misled. Up to 40 and even up to 55% of them will have BIV failure. And especially if they start to develop acute hypoxic respiratory failure, these are patients in which an earlier intervention is needed. And so VA ECMO certainly plays a big role. We're seeing that now with these patients coming in with unfortunate COVID myocarditis. I think early VA ECMO in these patients is a very important question. But the second important question is, what about early LV unloading? We don't have any randomized control trials at this time to look at LV unloading in these patients. There's been meta-analyses. First that was published about 1.5 years ago out of JACC, and then now more recently a larger number of meta-analyses that came out of Europe, which would suggest earlier LV unloading in these patients may help to facilitate earlier weaning off ECMO. So with all that retrograde flow from the extracorporeal circuit in the iliofemoral system, we're generating great blood pressure. That translates into a lot of increased afterload and pressure in the left ventricle. The LV starts to distend. The aortic valve doesn't start to open. You're at risk for LV thrombus, aortic root thrombus, and ultimately pulmonary edema. So to answer your question, I think whether to implement LV unloading early, we don't have randomized controlled trials to answer that question. But I think it's one of those things that can really, with a PA catheter early in the cath lab, one can decide that. One of the benefits of unloading these patients early is that that LV unloading device, whether it's Impella or atrial septostomy, whichever you have a stronger clinical level of confidence in, can facilitate, can serve as a bridge, if you will, either to myocardial recovery or cardiac resynchronization therapy. But it does unfortunately come at the risk of vascular complications. The larger the sheath, the more devices, the higher the rate of complications. There's some data, although it's all observational and there's no randomized controlled trials, that perhaps an atrial septostomy in these patients may facilitate lowering of the wedge and the PA diastolic pressure earlier. And because it's only a single venous access, it doesn't put the patient at the risk of further complications by requiring a 14 French arterial sheath that the Impella requires. And also, it doesn't also put the patient at the same level of risk for mollicystic pigment-induced nephropathy that a patient may develop with these axial flow devices.
That's amazing. We are need to transition to the next speaker, Behnam. We're going to want you back. This was amazing. We also might want, and Eddie and Sherry can send a questionnaire out if the member institutions want to set up a work group on shock management, and we can share protocols and then track impact. So we'll pursue that. That was one of the things that we wanted to export best practices and options for the future. At this point, it is a delight and a pleasure for me to introduce our next speaker, who is Dr. Daniel Carey. Dan was appointed Secretary of Health and Human Resources by Governor Ralph Northam in January of 2018. Prior to that, Dr. Carey worked for over 20 years as a cardiologist in Lynchburg at Centra Health and served as Senior Vice President and Chief Medical Officer there, where his responsibilities included information technology, services, patient quality and safety efforts, performance improvement initiatives, and functions of the medical staff at Centra's 3 acute care facilities. On a personal note, I've known Dan for several years prior to his appointment. He's a cardiologist from a superlative group in Lynchburg, and an amazing guy. The Commonwealth is very fortunate to have Dan as the Secretary of Health and Human Resources. And we are incredibly fortunate to have Dr. Carey tonight to discuss COVID-19 issues. We've been wrapped up in COVID-19, and I thought, who would be a better person to ask to get involved? And we are incredibly, and I personally incredibly in debt and grateful for Dr. Carey joining us. We sent questions to members, or asked members to send questions they had about COVID-19. And so the questions that Dr. Carey will be answering are based on what the questions you submitted as members. So thank you for that. And lastly, if you have additional questions, just send them via the chat. And if we can't get them answered now, we will do our darndest to get them answered in the future. So with that, welcome, Dr. Carey.
Thanks so much. I'm looking to make sure, one, you can hear me, and two, that I can't see my video to know whether I'm in focus, but I should, can you all see me okay?
Yes and yes.
Okay, very good. And thank you so much, Bob, for that very nice introduction. It's a pleasure to be with you all. And I also scanned down and saw that my old partner, Pete O'Brien, is also there. So, hey, Pete, it's been 6 years since we did cases together. Hey, Peter.
Hey, sorry. Thanks for coming, Dan. Look forward to your talk.
Well, thank you. And I just want to say there's not a day or two that doesn't go by that I don't miss all the great cases we did together. Peter and I did the exact same procedures. Many of us did intervention, but he and I were two of the original peripheral vascular cardiologists setting up our vascular program and carotid stent program together, and participated. We were principal investigators in the renal artery stent trial from NIH as well. So I miss it, and I will say, in the midst of COVID-19, I miss it even more. But maybe a little bit on background about you gave that, and I'll simply say I love being a cardiologist. I still miss it, and at the same time, I really do enjoy the broader leadership and healthcare and now public health role that I'm so honored to play in the Northern administration. I was the chief medical officer at Centra for about 4.5 years, and I was pulled into that really not because I did enjoy being the medical director of the Cardiovascular Center, but because, frankly, I was asked, hey, how about coming and working to head the medical group and helping provide primary care and build out access for 500,000 Virginians in Central and Southside Virginia. And I just couldn't say no to that. And then 4.5 years later, I was asked by the governor to serve in this role to help get Medicaid expanded in Virginia and better provide for the health and human services for 8.5 million Virginians. So I am honored by that. It's a pleasure to serve and a great challenge, and I'm very humbled by this. So thank you for this opportunity, Bob, to be with you all. A few things about COVID-19 were that first case in Virginia occurred on Saturday, March 7th. I remember because it was the last day of the General Assembly session, and we had just passed a historic legislation, a historic budget with almost $1 billion new dollars invested in health and human services, maternal health, equity issues, an oral benefit in Medicaid, eliminating the 40-quarter rule for eligibility in Medicaid, home visiting for pregnant women and women with newly having given birth, and a host of other incredible initiatives. And much of that, unfortunately, is on hold because of the uncertainty in the budget. It's called allocation, and we've unallocated a number of new initiatives until we understand what the impact of COVID-19 will be on the state budget. We did all of that without raising taxes, except for attempting to fund a reinsurance program with a cigarette tax increase, and also there were some gas tax increases, only to make up for the fact that roads are being used more than ever before, but the mileage and gas mileage is appropriately much better, and we needed to adjust for that. So all of that is on hold right now as we understand what the fiscal situation in Virginia will be in the wake of COVID-19, and we look forward to a reforecast likely in July and a special session called in August to look at the state budget and where we are. It's likely better than we thought, and we'll more to come on that. So it's been 12 weeks or so into COVID-19. Today, we're looking at 47,800 cases here in Virginia, 951 cases today reported. That's not when they occurred, but when their positive tests were reported. And we're looking at a number of key indicators as we look in most of Virginia to go into phase 2 tomorrow. And again, the hospital capacity is excellent. PPE, at least for hospitals through conservation, has been excellent. So number of people on a ventilator in Virginia with COVID-19, number in the ICU continues to fall, including in Northern Virginia. So those are all good signs. Our testing capacity is dramatically increased, over 11,000 test results for PCR reported today. So, excuse me, so that those are good indices, but again, we're always looking for, is there evidence of a rebound? Is there evidence for things not going in the current trend? So stay tuned, we'll be looking at that. Excuse me. So we began with testing capacity and PPE still being at the center of our concerns, and they remain there now as we try to make sure we have enough testing capacity both for all symptomatic individuals as well as for contact tracing, and we can talk more about that as we move forward. I did want to mention a couple of things. COVID Check is a program from Bowie Health out of Boston that is a great resource. So mention that to your patients. It's available on the VDH website that goes through both a questionnaire as to your symptoms and whether you should seek medical care. Is it likely to be COVID-19? And also refers you, whether you're uninsured or with a specific health plan, to telehealth services and also to testing in your region. So that's an important tool I wanted to make everyone aware of. And also to mention that we are focusing on facial coverings in the public. And that is, as we look at the curves and we look at the models that UVA complexity center has put together, we really see the power that social distancing made. And through both use of facial coverings and continued physical distancing, even as we open up, those remain incredibly important public health measures. And then it's contact tracing and containment efforts going forward until we have either a prophylactic drug or we have a vaccine. So I did want to mention those things before going into questions. I know PPE has been a big issue. The hospitals have, through their supply chain, have learned very well to conserve and reprocess and reuse. That has not, the supply chains into long-term care facilities, into private practices has been more challenging. And actually, as the state goes into the marketplace and orders large supplies to be able to supply first responders in locality, as well as focusing on long-term care facilities, and then down the priority list, we realize we're actually competing without a federal national program. We are actually just competing against each other, even as we try to help each other, and that remains the case. The feedback we're getting from supply chain and from end users is that it's getting better slowly. But for example, isolation gowns remain very much in need. I do want to thank everyone for reducing elective procedures, eliminating elective procedures. I know we've gone back to that, and I know that once you turn that on, it doesn't immediately go back to normal, as we need to restore confidence in the healthcare system of keeping people safe and free of exposure to COVID-19 going forward. So with those prefatory remarks, I wanted to just start out, and now we're ready to go into specific questions. And we had a lot of questions, and we wanted to talk for perhaps 30 minutes or so, but then open it up to other comments so that I could hear your concerns as we move forward. And I don't know with the slides whether we'll have questions on the slides or I'll go from the notes that I have. Is there another slide next with questions on it? Yeah, testing. Yeah, what are the plans both for screening for COVID-19 antibody testing in the Commonwealth? So again, our first priorities historically were based on having availability of hundreds of tests in Virginia. Now we've got we've been consistently between 7,000 and 12,000 tests a day for the last 7 to 10 days. So we really have increased capacity. That comes from private sector and hospitals and FQHCs, as well as now coming on board CVS, Walmart, and other venues. But it also includes significant screening for both symptomatic and asymptomatic high-risk populations across the Commonwealth. We've done a number of events in Northern Virginia, as well as in other cities across Virginia, both small and large testing events to at high-risk populations. And folks have said, how do you know that those are you're screening the right people or touching the right people? Well, our positivity rates in those events are in the 10 to 18% range. So we know that there is significant disease burden of asymptomatic and symptomatic folks that are touched with those events. So again, we need to continue to increase our testing capacity going forward, as both to identify, but also to contain and to eliminate this disease in the Commonwealth. So the question really was, what are our plans for screening? We will, well, I'll go to the second question first, antibody testing. The role of antibody testing is for the individual remains a little bit unclear. We don't know whether a positive IgG antibody, they're not 100% specific, they're not 100% sensitive. There is cross-reactivity with other coronaviruses. We also know that that we don't know whether a positive IgG confers long-term immunity. It likely does. So right now we have a study that's planned by the state, coordinated by UVA in conjunction with 5 health systems, around the Commonwealth to test 5,000 folks of in an epidemiological prevalence study that's going to start in June and towards the end of July to get a baseline prevalence across with a representative sample across the Commonwealth. And I think that will be helpful to understand what is the herd immunity and how extensive has been the exposure. I think we'll learn more whether antibody testing, how useful it is for the individual, whether it's a healthcare worker. I don't think we're anywhere near saying that healthcare worker, whether a cardiac surgeon or a cardiologist or nurse, should be going into an ICU without personal protective equipment with a patient with COVID-19 if you do have whatever is considered an adequate titer of IgG. So that remains to be seen going forward. So I think from the recommendations for the CDC is that, first of all, we should be using FDA approved tests that are highly reliable and not simply approved under the emergency use authorization. So that's first and foremost. So the tests are getting better, and we are using an FDA approved test as part of our test for the Commonwealth. So in screening, I think that we at the state level understand that from our clinical basis that clinicians are welcome to use tests as they see fit in terms of screening prior to elective surgery. CDC offers that as an option. It's not unreasonable. We have not taken a stand as to how we screen all people in the Commonwealth, but our goal is to make sure that for contact tracing, those have had exposures, and for those that, in terms of returning to work after COVID-19 or returning to environments, there's guidance from VDH coming from the CDC on both a symptom-based strategy in terms of being 7 to 10 days into your course and 3 days without fevers or other symptoms, then it is reasonably safe to go back to work. Some employers are requiring 2 negative tests, not just 1 negative test. So that is certainly not based on CDC guidance, and I've not seen literature that says that that's indeed what is required. So that's really the answer to that question. Next question. Are there recommendations for pre-procedural testing for COVID-19? I think those are coming mostly from societies. From the CDC, it is considered optional and reasonable. Our perspective has been that if there is manipulation of the airway in particular, that for worker exposures, you'd want to know whether someone had COVID-19, and I think that has become the common practice in the Commonwealth. And access to testing was an initial challenge to that, but I think just as we've moved back into elective procedures, it has occurred at a time where at the health system level or the commercial lab, whether it's LabCorp or a number of independent private labs in the Commonwealth with turnaround times of less than 72 hours, often less than 48 hours, that is indeed available. So that really has been more on the clinical side than the public health side, and I think that certainly is reasonable, although there is some diversity throughout the Commonwealth as to what institutions are doing. So we haven't prescribed exactly how that needs to be done, and hopefully in our time together I can hear how your institution is doing it, whether it's before catheterization or EP studies or cardiac surgery. So I look forward to hearing more. Next question. Yeah, I think that's really the challenge. The PCR tests, the polymerase chain reaction tests, are the gold standard for diagnostic work, and that is really where the great accuracies is. There is a lot of research about blood tests for markers where whether it's inflammatory cells that are relatively specific for COVID-19 are visible even before symptoms, and that may allow for testing that doesn't require a nasal or oral swab, and the test can be done on blood and much more rapidly and at scale. So that remains to be seen. In terms of antibody testing, specificity and sensitivity. You know, as you all know, with cardiovascular medicine, Bayes' theorem and the like, prevalence does determine the effective, you know, the positive and negative predictive value. And the challenge is with sensitivities, the issue is what's the negative predictive value. And unless you're very high, then your negative predictive value will be suboptimal. And in terms of the specificity, the false positive rate, if the prevalence is low, and it is in many parts of Virginia, that unless your specificity is very, very high, your positive predictive value will be very, very poor, in that your false positives to true positives will be very unfavorable, and you'll have to have some gold standard test for 80 or 90% of your folks who test positive. And for HIV, there was the Western blot, and then other tests. There clearly was a gold standard test to go to, and a highly sensitive screening test, and then a highly specific confirmatory test available. That does not exist yet with COVID-19. So that remains to be seen. Again, how to use, I think, for population-based studies, antibody testing will be incredibly useful. I know that lots of health systems in New York and New Jersey early on went with antibody testing, and it's maybe helpful to know whether that, you know, mildly symptomatic illness that you had, that really you're now testing positive. And here in Virginia, Senator Kane has been very public about that, and also his wife, Ann Holton, who's the interim president of George Mason, have been very public about their positive antibody test, and in retrospect, their likely illness in March and one in April a long time ago. So I think it's, again, unclear exactly how to use that, and whether that confers long-term immunity, and whether it confers immunity that would affect workers in healthcare environments that may be subsequently exposed to COVID-19. Next question. Yeah, the second wave, and I think as I spent an hour with the Complexity Institute at UVA that we've contracted with to do modeling for VDH, and looking at how their model is going, and different models of very aggressive contact tracing and identification, and versus a strong or weak or mild rebound, depending. I think those models are actually looking pretty good for the summer. I think we've figured out how to test more. We figured out how to, as our contact tracing workforce increases. I've been on several calls today to talk about that, and I don't think I've mentioned on this call that we started with a little over 200 contact tracers within VDH, mostly in their SCD program and tuberculosis. We have grown that to almost 500, even before we've now hired an additional 200, on our way to 1,000 contact tracers, to get to at least 15 per 100,000 population, which for us is in the 12 to 1,300 range. But we may indeed need, depending on how we use our call center, how we are able to use a exposure notification app that we're working on with Google Cloud and a company called Spring ML. We'll need to do a lot of advertisement that's ready in 2 to 3 weeks to get that on folks' Android, as well as the Apple platform, and also get folks to trust us to not retain that information. And again, that's part of that what Google and Apple are doing together to make that that information cannot be shared, and that will be very, very important. So our plans for testing is to increase that capacity up to 20,000 tests per day by the end of the summer, and be ready for that second wave. But again, it's going to be all about finding who are the cases, who are their contacts, isolating I think, again, testing is nice for the contacts, but what's really even more important, because tests, again, can be about it's a point in time only. that could turn positive in a day or 2 days or 3 days is really to make sure that they're in isolation. And if they can't be isolated within the home, that we provide resources in hotels and other settings to make sure that folks can truly be isolated for a full 14 days. So testing is part of that, but it's not nearly as important as isolation and monitoring that. So that's critically important. And we are prepared for, depending on how effective that ratio of 15 to 100,000 is, we're prepared to then hire up to 30 per 100,000 to go to the upper limit. Next question. Reopening. How are other hospitals helping build the confidence in patients that the hospitals and safe? And again, you all likely know that better than I do in my calls with health system executives, as well as with practicing providers. What I'm hearing is that it's happening slowly. We see that, unfortunately, early on, folks were not coming to the ED with heart attacks. They were not coming early with strokes, and opportunities to intervene were missed. And we're still seeing a gradual increase in the utilization, appropriate utilization of emergency services. And I think that hospitals have done it with moving more to face-to-face clinic visits. Helps, again, build that confidence that coming to a healthcare facility is not a scary thing, and that you can trust that there are precautions in place and appropriate PPE is needed. And I think also as we open up, hospitals are also, I won't say dramatically loosening, but loosening a bit their visitation policies, and also universal facial covering and hand hygiene. Again, I think that use of facial covering, impeccable hygiene, whether it's with hand hygiene or also treating surfaces, effective screening for symptoms and folks who are symptomatic. I realize that asymptomatic folks are out there, but again, focusing on the basics of hand hygiene, facial covering, isolation, and screening are still the public health stalwarts that will, I think, really make a difference in this pandemic. Next question. I think
this one is actually a repeat here.
Yeah. So maybe the next one. PPE. Yep. Well, I've mentioned a bit coordinated. I think the PPE. Again, I think the health systems with regional coalitions. There are 6 regional healthcare coalitions that are funded through a CDC grant, a FEMA grant through the Virginia Department of Health. That the contract is with the Virginia Hospital and Healthcare Association, and they do include skilled nursing facilities. They do not include assisted living facilities, but sharing PPE, sharing best practices. And I will mention that Battelle is a commercial firm that's been contracted with by FEMA. We have a system in Blacksburg that we share with West Virginia. There's one in DC for Northern Virginia. There's one in Tidewater, and there's one here in the central region in Richmond. And it's exclusively for N95 mask of a particular type, but it can do hundreds of thousands of these with hydrogen peroxide. And we are making sure that that is known. And there's you send it to them by FedEx, and you get it back by FedEx, and you label it, and it's free. So critically important that our health systems are using that to preserve their N95. And in most N95s, and there's lots of guidance about what models can be used and which ones can't, but most actually it's most can be. And so I just wanted to put that plug in. If your health system is not using Battelle, then you really do need to nudge them to do so. In terms of the state PPE coordination, we do use the Virginia Department of Emergency Management with the Virginia Emergency Support Team that comes together during declared emergencies to work on different aspects of emergencies, and PPE as well as testing have been 2 of the ones from day one. And health systems are indeed, through the 6 healthcare coalitions, looking at PPE. And also the health systems have been aggressive going into the market and securing it, and also have reduced their consumption by about 70 to 80%. And you clinicians on the front lines have certainly seen that. And I will say the coordination is not at the purchasing side. It's been a free-for-all, and it continues to be a free-for-all. There's no federal clearinghouse of how to rationalize that. So again, that competition, even as we try to support each other, has continued. And we have 747s coming into Chicago and Dulles from the Far East that we've put a $30 million order in. And we don't know, we weren't competing with Centera and Inova and VCU and UVA, the same systems that we're trying to help. So that has continued, and unfortunately there is not national guidance or coordination. So we're trying to provide that, but we've got to go out into the marketplace and get it first. And there's been some use of the War Production Act with 3M, and that has helped somewhat, but not as aggressively as we would like. So I'll maybe go to the next question, and then maybe open it up for any questions in person. Financial, right? The health systems. This is a question about CARES Act and other federal monies that went to healthcare systems, and where it goes once it gets there. And providers have been laid off or furloughed and have had salaries cut. And I know that there's been contributions to retirement plans that have been cut. And does the state have a comment? Well, we certainly, federal monies that go directly to health systems are monitored by the federal government. We are asking for health systems to account for that as we consider paying for additional testing capacity, for example, and also using CARES Act funds there's been a number of asks from the health systems and from the Virginia Hospital and Healthcare Association, and we are considering what should be done to help support them. There's no question that $700-800 million a month loss in March and in April because of reduced volumes and holding back on elective procedures that require PPE, and again, a dramatic cut in imaging, because those are often done to support a surgical and other interventional procedures. So I will simply say our view is that before we give additional funds to specific healthcare systems, we are looking for how those monies were used and were they used for testing, were they to expand testing capacity, so we're not paying twice for the same thing. So at the same time, there's no questioning the dramatic impact it has had to the bottom line of for-profit, not-for-profit healthcare systems in Virginia. And with increasing volumes of elective and non-urgent treatment, and as patients get more confident into the safety of the healthcare environment, that has improved, but it's certainly not back to normal. So those are my comments there. Maybe one more question and open it up to comments from the attendees. Yeah, I think that we've heard, so this you can read the question there. It really has to do with a number of initiatives with telehealth visits. And I think the biggest question, for example, when talking to and not just from this question, but also from a number of folks, what we've heard is folks are not, I mean, Anthem went out that to the end of September, they're continuing their current telehealth policies. When you talk to the payers, as well as to DMAS for Medicaid, the question really is for things like physical therapy. Talking over the phone for physical therapy when there's not a video component is probably not that effective. So also the over the phone visits and email stuff, that has been critically important. I myself had a number of visits. One was with a phone only for follow-up of one of my issues, and that was highly effective. And another visit with a provider over the phone. My primary care person moved away from VCU, and I had a new patient visit in the last week, and it was done with video, incredibly effective. And I have no doubt that the quality was as high, and hopefully we're learning the lessons that should be continued, both with government payers and with private payers. So in terms of that discussion is occurring both at the Bureau of Insurance, private commercial insurance that is not ERISA regulated, which is through the Department of Labor federally, is regulated in Virginia by the Bureau of Insurance, which is part of the State Corporation Commission, which is governed as an independent body, but we obviously have influence as the administration. So we have set up conversations with the Bureau of Insurance around covering telehealth services. Dr. Karen Ruban, a pediatric cardiologist at UVA, really a pioneer in telehealth services in Virginia, continue to chair our telehealth work group. And again, we want to make sure that telehealth increases access in Virginia, both in public payers and private payers. And at the same time, there does need to be accountability, especially with things like physical therapy. And I think some of the fears of reimbursement changing as early as June have not been realized. We talked with the Virginia provider group. Bob, I know you're quite concerned about that. We have not had any of those concerns validated, and if that is not true, I certainly want to hear about it. So why don't we end it? I've got a little before 10 after. I know I've gone longer, but these are great questions, and I hope I've given, if not, sometimes the answers aren't entirely clear even now, but I hope I've shared the Commonwealth's perspective.
Thanks, Dan. This was fabulous, shedding light on confusion surrounding COVID-19. I think Dr. Spear had a question. Alan, did you want to go ahead?
Yes, thank you, Dr. Carey. My name's Alan Spear. I'm the chairman of cardiac surgery for the Inova Health System and a founder and the previous chairman of this organization. And we're so pleased and privileged for you to take time to join us this evening. With our over 25 years of improving quality and reducing costs, we've tried to work with some of your predecessors and only hope this is a forum to maybe work collaboratively with your office and what we are jointly trying to do, and for maybe coordinate or opportunities to coordinate together. So we look forward to that. My question regarding COVID, we're all very aware of the discrepancies of the patient populations across the Commonwealth and the disproportionate number of patients in the Northern Virginia area, Richmond and Norfolk, and the extraordinary stress on the providers and the institutions regarding testing and then PPEs. And on a personal note, what have you learned through this experience during these past several months that perhaps upon reflection, we all could have done better to either facilitate access, have greater responsiveness, and with the profound lack of confidence in the CDC, much of this will come to you and your office and your successors in the years to come. And what could we do differently if such a catastrophic occurrence occurs?
Well, thank you very much, Dr. Spear. I remember meeting you at my first meeting of that organization back in whether 2008 or 2009, and I know Centra Health had been an original participant. Dr. John Bell, who died unfortunately in a bike accident years ago, was an active participant. So I certainly remember the incredible value of your organization, of this organization, as a clinician and as a physician leader. So certainly understand the value. Lessons learned, it's, I will say the synergism in Virginia, since we were not an early state, we were not early affected. So many of the resources went so quickly to the hotspots that if we had, could we have reacted more quickly to secure PPE, to secure testing capacity, because they really are and remain interrelated, that the normal testing, what we've done is we've used a sledgehammer to get massive testing events around Virginia, focusing at-risk communities, whether it's the Latinx and Hispanic community, or the African American community, or the Creole Haitian community on the Eastern Shore involved with the poultry industry. We've really got our testing up, and we are identifying those folks much better than we were. But the understanding that interrelatedness of PPE to testing access, and our goal is now to move from a sledgehammer to a scalpel in the months ahead, to connect testing to places that are normally within the care, whether it's at federally qualified health centers, at free clinics, even at CVS, to make that a regular part of folks can go and get their testing under the advice of a clinician, or even with the advice of their work group, and they're getting, as part of occupational health, getting a test that's covered by their work. But I think, you know, there's plenty of shoulda, woulda, couldas, but we understood that relationship, and yet getting much of the stuff was being pushed to the hot areas that you didn't, you know, we did act aggressively to order PPE. We did. I think maybe the one thing is to move towards massive community testing a little bit earlier. But I do think, as you look in Virginia of our mortality, and we did move early to socially distance. We did stop transmission, and the doubling time went from 2 days to 3 days to 6 days to 9 days, now out 15 days or longer. And our not as a Commonwealth remains slightly under 1, which means that we're going to extinguish this if it doesn't bounce, and it probably will bounce in the future. So I think the lessons are still being learned. I think we've got to be ready for the next, for whatever that next wave is. And I think it's going to be one with classic public health, contact tracing and quarantine and the like. And I think that capacity and also exposure notification. Testing is part of it, but you know, testing is a point in time, and we keep thinking that it somehow confers, unless you're willing to test everybody every 7 days, which is logistically just hard to conceive of and to afford, then you need to be selective. And I think, again, it's what we've talked about with those basics. Atul Gawande has written about it in the New Yorker. So great question. I hope I've given some perspective on that, Dr. Spear.
Thank you again.
Thanks so much. Well, maybe one more question. I've actually got another call to be on. I guess was on with our congressional delegation up until this call. So I really do appreciate this opportunity. Appreciate the work that you all are doing. Maybe one more question before you continue with the rest of the program.
I guess, Dan, one quick question as we think about the next wave, if we have the next wave. I thought I heard from you, do you have any prediction on the next wave based on the models?
Well, I think the models, they're not, you know, and they're on the VDH website, so we're not holding back on at the same time, as you know, if an epidemic gets going, it can become logarithmic. It didn't in Virginia. It didn't in this country. It came close to it in New York and New Jersey because we intervene, and we're going to intervene if we have to. We know that this is a public health crisis as well as an economic crisis, but we can't address the economic crisis fully until we really address the public health crisis. So we know where the priority has to be. Having said that, we realize that, you know, for many businesses to have to reclose again is the end of them. And we know that economic, but also the public health impact of mass unemployment and loss of coverage. So predictions, I mean, right now, what I learned today from, I got a weekly update from the the folks from both from the RAND Corporation that look at multiple models around the country, as well as from the UVA complexity team. And it's reassuring because it shows the impact of what we've done. It's a little early to see what phase 1 impact has been. We should know much more. Well, really the last 3 days and then the next 3 or 4 days to know about phase 1 and its impact. And the signs look really good to go into phase 2 for all but Northern Virginia and Richmond tomorrow. But we're looking at what the August might bring. That would be 6 or 8 weeks after phase 2 or a potential phase 3. If it gets going again, again, there's a momentum there that you've got to be willing to deal with. And the models really are a little bit simplistic in that they presume certain levels of back to that facial coverings have an impact or don't, and the like, and hygiene measures, and then what the contact tracing and containment interventions, how effective they are. And I will say that the models are pretty favorable for 2 or 3 levels of those things, and I think they're synergistic. So I remain very optimistic. I can't tell you though, as higher ed tries to reopen and what a major outbreak might look like at a large institution. And so we're really concerned about that and how to contain that. So I remain optimistic, but again, we've got to be really diligent about the basics. And that means social distancing within the context of the phase 2 plans and as we're working on phase 3. So again, until we get a vaccine, I think which again, is that a year away? Is that even 16 months away? So I think this is our new normal, and we're going to have to get comfortable with it, vigilance, and the ability to inch forward and be willing, if the data indicates that we need to inch backward, to reimpose some of our social distancing interventions. So with that, Bob, one last word. Thank you so much for this opportunity. I will say that I am so appreciative and admiring of the great work, quality work, and really trend-setting work that this organization means in the Commonwealth, and first with cardiac surgery and now more recently with additional aspects of cardiovascular care. You really are setting the standard for high quality care, that appropriate care that reduce costs and increase quality, increase standardization, decrease inappropriate variation. So you have really set the standard in Virginia. I'm so proud to have understand your work, participated in your work in the past, and so glad that your work is as vibrant as ever and continuing to increase in its influence. So thank you all very much. Really appreciate you, and have a great evening. And I'll ask Dr. O'Brien to say hey to all my friends at Centra and in Lynchburg. So
Will do. Thank you.
Bob.
Thank you so much. Really appreciate it.
Thank you.
Bye-bye now.
Good night.
Thanks.
And with that, that essentially concludes our program and our planned content. Dr. Spear, Dr. Shor, anyone else? Do you have closing comments, questions for the group?
I just wanted to have a huge thank you to Dan and to all of the presenters, to the board, to the members, particularly with regard to the survey questions and posing questions for Dr. Carey. This just shows the value of what we can do together. So a huge, huge thank you. And for me personally, I stand on the shoulders of giants like Alan and the other folks. So this has been an honor for me as well.
Great job, everyone. And what a pleasure. I think I wish that some of Dr. Carey's answers had been more definitive, because it also shows us as we go forward how much there is to learn and how much there is to confront on this evolution of this pandemic. We're not out of the woods by any means. There's so much to be confronted, But thankfully, by having this type of collaboration and sharing what we know and what we don't know, some of these things will be made clear. But a great evening, great job, Robert and Eddie and Sherry, and thank you all so much for the organization. So good evening.
All right. Thanks, everyone.
Thank you.
One quick thing is the meeting was recorded, so we'll send out that link to everybody if you missed a portion of it, or like Dr. Tehrani's segment was really just dense with information, so we can refer back to that. We'll also send out the slides via our newsletter. And again, thanks to everyone for being a part of our community. We appreciate you. Be safe, be well.
Thanks.